that we have actually gotten through everyone in this list early. So I'm going to close the informational or the public hearing on House Bill 2469 and open a public hearing on House Bill 2980, Peer Respite Centers. Zoe, can you give us a little information about the bill, please?
Yes, Madam Chair, members of the committee, House Bill 2980 directs the Oregon Health Authority to provide funding to peer-run organizations to operate peer respite centers, specifies that peer respite centers should be located in Portland metropolitan area, Southern Oregon region, and Eastern Oregon region, requires peer-run organizations to allow OHA to access peer respite centers for investigations and assessments, defines peer respite services, peer-run organizations, and peer support, allocates $2.25 million in general fund money to provide $750,000 to each peer respite center, declares emergency effective on passage.
Thank you, Zoe. Representative Cedric Hayden.
Thank you, Madam Chair. Thank you, members of the committee. The House bill before you, 2980, is
Your name for the record, please. Your name for the record, please.
Yes, sorry, Madam Chair. My name is Cedric Hayden, State Representative from House District 7. The House bill before you, 2980, is a bill that we've had prior. It's been through the House Healthcare Committee. Didn't make it all the way. I believe we had unanimous vote on that. Here is the concept, and we've got some good testimony to follow, so I'll be fairly brief. The concept is that we have a gap in our mental health system between going to a state hospital or getting held in a regular hospital on a mental health hold, and we don't have anywhere for people to have beds or a respite center. So we want to create in that gap between having to send somebody to a state hospital or having them held long-term in a regular hospital. We want an area to send these folks, and this would be called a peer respite center with peer-based folks there, people that have lived experience with it. The idea is to have the Oregon Health Plan set up 3 of these, one in metropolitan, one in Southern Oregon, and one in Eastern Oregon. We haven't called out exactly where, but in my mind, the concept is for them, the Oregon Health Authority, to work with organizations like Cahoots in Lane County. Now, Cahoots has been functioning for a long time. They do ride-alongs. They interface with law enforcement, and they send counselors, sometimes instead of law enforcement or along with law enforcement, so that they can treat on the site for people that are about to or have gone into crisis. But what we don't have is a bed for them to go to. We don't have a short-term place for them to rest for a few nights. And so this would be like adding 6 beds per center is the concept. Now, the bill doesn't lay out this detail because we want the Oregon Health to set it up, but the concept is to add 6 beds per center where if they have a contact with somebody, they have a place to go, a pillow to sleep on, and a warm place to rest, so that they keep them out of the crisis, they keep them out of the hospital. And so we have some testimony that has some lived experience with this, and I think it's just a wonderful bill, and it would fill a gap that we don't currently have in Oregon. Thank you.
Thank you, Representative Hayden. Are there any questions for the representative? Great, we will move on then. Karena Frenmire? Are you here with us? Karena, looks like. Frenmire?
Hello, can you hear me?
I can hear you now.
Oh, okay. I was going to try to do this by video, but I'm having some technical problems, so I'm feeling really weird right now. But I guess I'm not going to be able to make this video work, so I'll continue by phone. Am I doing this right?
Yes, you're doing fine. Your name for the record.
Okay. Hi. Hello, Chair Sanchez and committee members. My name is Karena Frenmire. I live in Portland, Multnomah County, And I am participating in this meeting to urge you to support House Bill 2980 to establish peer respites in Oregon. Okay, so briefly, I'm excited about this bill because it would establish peer support services by peer-run organizations to fill a gap in mental health services in Oregon. I really know the value of peer support and peer-run organizations because I started to make great progress in managing my own depression and anxiety illnesses when I worked at a large peer-run mental health agency in Philadelphia, Pennsylvania. Peer-run organizations are different from other types of mental health organizations because encouragement, inspiration, and accountability for self-care were just far more compelling to me when they were modeled by my coworker peers who had overcome mental health challenges that were even beyond what I had experienced. Peer support inspires personal responsibility and self-determination in a way that therapists and doctors and social workers can't. In addition to my own personal experience with peer-run organizations, this specific peer respite model is particularly appealing to me for Oregon right now, based on my experience in a 20-year relationship with a wonderful person who has a, quote, severe mental illness, unquote. We're doing pretty well right now, but we have had a number of years that have been very rough. And a lot of that rough time, in addition to his symptoms and my symptoms, were due to housing instability, because when he would be unable to just chill out after 10 o'clock when you're supposed to be quiet in an apartment, we had a hard time having staying in apartments. There was 1-2 year period where we moved 3 times, and each time it was really, we didn't know what the former landlords were going to say about us and if we were going to be able to get an apartment. So it's just incredibly stressful when people who are in extreme distress have nowhere to go. Outpatient services, they're great. But if you need something a little extra in Oregon, that's the hospital. And there are a lot of people who are just not bad enough to go to a hospital. Or if they do try to go to a hospital, they get turned away if they're not a danger to self or others. And Oregon really needs something in the middle where someone who just needs a little extra help can go and be with some people who know what it's like to hear voices, know what it's like to have paranoid delusions, and can stay with you and listen and give you tips for getting back to something a little bit more normal. So the peer respite model would do a lot to fill that gap. And so I'm a big fan of the peer respite model. It's been implemented in 14 other state systems. So this isn't just something that we pulled out of our ears and thought, this looks good. This is a successful model in 14 other state systems, and I'd really love to see it implemented here in Oregon.
Thank you. Thank you, Karena. Dwight Holton.
Good morning, Chair Sanchez, members of the committee. My name is Dwight Holton, and I am the Executive Director of Lines for Life, a nonprofit dedicated to preventing substance abuse and suicide and promoting mental wellness, and also a proud constituent of Vice Chair Nose. Lines for Life is fully supportive of this legislation to provide for peer respite centers. in part because peer respite centers are just a natural and essential part of the solution for our currently fractured and inadequate crisis intervention system. And I think this bill comes at a perfect time because as we look to the future of crisis intervention in Oregon as well as throughout the nation, we're shifting now to this 988 model. As many of you know, Chair Sanchez has been deeply involved in this. Oregon, along with the rest of the country, is going to adopt 988 as a 3-digit access to behavioral health services. So just as we have 911 for fire and medical emergency, we'll have 988 for behavioral health emergency. 988 will distribute calls to the National Suicide Prevention Lifeline, which Lines for Life and Northwest Human Solutions answer in Oregon. And what happens next is the big question, because we expect significant growth in volume. Lines for Life took about 30,000 crisis calls last year in Oregon. SAMHSA and our folks at the National Suicide Prevention Lifeline tell us we can expect more like 135 to 210 by 2024. 135 to 210,000 calls in Oregon by the year 2024, and building a system that is ready to deliver the right kind of help at the right time with the right treatment folks and the right support to people is essential. Peer respite is an essential part of that leg. We kind of envision 3 legs of the stools: the call center, a mobile response, and stabilization. And to the extent we can do peer stabilization with peer respite centers, we know that it's a healthier, often lower cost outcome, lower cost model. We see this as essential and urge the committee to adopt this and move forward.
Thank you so much. Angel. That's all the name. It's the only name I have here. Angel.
Thank you, Madam Chair. Hi, my name is Angel Prater. I'm the CEO of Aware Consulting Group and previously the Executive Director of Folktime, which is in Portland, Oregon, and has been for over 33 years. I'm in favor of peer respite model, House Bill 2980, and I've been actually advocating for a peer-run respite in Oregon for nearly 2 decades. As a person with my own mental health and addiction history, I and many others would have used a peer-run respite over my 24 years in my recovery journey. Peer-run respites should be the standard, not merely an alternative. As a business professional, I find myself continually frustrated now how the money is allocated to spend on costly and often ineffective models of the dominant medical model deems as a care model. And that's not to say that I am demonizing the medical model. It's just creating more of the same models, resulting in creating more of the same poor outcomes and an excessive drain on our system. Despite the respite model, I did a cost analysis several years back. If we had one person at a respite model for 7 days, and you multiply 7 days by 52 weeks, we're looking at serving 260 people in 1 year at one respite home. An ER visit for one person for 7 days in an ER, multiplying that with 260 people, the cost is a minimum of $4,550,000, not including ambulatory calls, 911, police, etc. People use the ER as an entry point. No wonder the state historically has been in a deficit with financial deficit and poor outcomes, and ultimately people are dying. Our state and our entire country has built a broken system by other bill, obviously from what other bills and testimonies have said today. We have taught people to use the ER. We have taught them to use the ER as a way of getting respite. I'm not just talking about low-income people. I'm not just talking about people on who are houseless. I'm also talking about you. I'm talking about your family, your friends, your children, the future children of your children. Our model currently teaches them to use an ER as a way to get respite or help, and it's ineffective and very costly. I'm also talking about your doctors, your personal providers, your personal veterinarians. Doctors on average are dying by suicide 500 a year because they have no place to go. And I'll just leave you with this. It's because they're risking losing their licensure. This is a broken system. And I'll fast forward. Instead of risk, I'm sorry, I have ADD. So people are dying because they'd rather die than lose their license or their livelihood. And that is a really big issue. Respites can fill this gap for a confidential, safe place for people to go. And it should be the standard, and not looking at this as a cost savings, but a life savings and a cost reallocation. I don't believe $2 million is enough, but I'm ready to start with 3 respite centers in Oregon, so that then we can make this have more respite centers than we have ER doors, so that we can make it the standard and save some lives. Thank you very much. I appreciate your time.
Thank you. Kevin Fitz.
Yeah, hi, this is Kevin Fitz. I'm a volunteer with the Oregon Mental Health Consumers Association. Good morning, Representative Sanchez and Behavioral Health Committee. I just wanted to, first of all, I want to thank everybody who came forward to support peer respite. Some of you may or may not know, in 1999, I was working on a grant project with Governor Kitzhaber, and he sent me out to New Hampshire to look at what was the first peer respite model, as far as we know, developed in the nation, that developed out there in New Hampshire. So we've been trying, like Angel is right, we've been trying to bring peer respite to the consciousness of the behavioral health leadership and the legislature for the last 20 years, particularly. I also want to echo what Representative Hayden said. This bill, almost for verbatim, the text was in HB 2831 and passed Representative Salinas' House Healthcare Committee in 2019. One of the things that I wanted to make sure that you understood is Representative Greenlick, one of the last things that he tasked Steve Allen, who administers the Oregon Health Authority's Behavioral Health Administration, was how many councils, work groups, and committees do you have? And the last count, that was somewhere between 42 and 44. Why is that essential here? Because you folks may know me because I testified last week about HB 2313 and the Alcohol and Drug Policy Commission. But one of the things I want to let you know is that in 2020, the Oregon Behavioral Health Directors, Oregon Consumer Advisory Council, created by this legislature almost a decade ago, recommended unanimously that Pat Allen and Steve Allen put peer respite on their buy package for legislative session 2021. In a parallel process, Governor Brown kicked off in October 2019 a Behavioral Health Advisory Council, and 2 of those work groups, 2 of those committees on that 3-part council all recommended peer respite as a buy in legislative session 2021. So I think it's in trying to understand what this council does, what that council does, what the recommendations were. Those people believe in those processes and believe in peer respite as a great value to the system. One thing that I want to say particularly, that this, and Representative Hayden talked about it, if we have 18, if we're serving 6 or 7 people in these 3 peer respites, 21 people a day may have some intermediate voluntary safe place to go if they don't meet criteria for being locked in an acute psychiatric crisis ward. Why is that essential? A woman shared earlier, I have been in and out of psychiatric acute care wards 12 times in the last 10, 12 years. But I've also waited on a gurney for 14 more times saying, Mr. Fitz, I'm sorry, but you do not meet criteria. I know that you're having suicidal symptoms. I know that you're filled with self-harm ideas, but you seem to be calm and rational. Therefore, we cannot keep you here. Go home, and here's the crisis number to please call. Why is it essential to have somewhere in between your house and the locked psychiatric crisis ward? Because mental health episodes don't come on all at once, and early intervention is less traumatizing than institutions. And ultimately, this builds the skill set and exposes the patient or the client to the peer network, which leads to natural networks of support. I wanted to submit some language amendments, particularly I would like to make an amendment to help structure one of these exclusively or particularly for the BIPOC community in the metro area. Thank you so much, Representative Sanchez and committee members, for your time. Again, Kevin Fitz, I'm a volunteer with the Oregon Mental Health Consumers Association. Thank you very much.
Thank you, Kevin. Jonathan Vetlinski. I think I got that one right.
You did. Thank you, Chair Sanchez. I appreciate that. For the record, my name is, I should start this formally. Chair Sanchez and members of the committee, for the record, my name is Dr. Jonathan Vetlinski, and I am an adult psychiatrist who currently serves as the Director of Public Psychiatry at OHSU. I'm here today to testify in support of House Bill 2980, which would provide funding to operate 3 6-person peer respite centers in Oregon. As you are no doubt aware, a peer respite center is a voluntary short-term overnight program that provides community-based, non-clinical crisis support to help individuals experiencing a mental health crisis find new understanding and ways to move forward. Peer respite centers operate 24 hours a day in a home-like environment and are staffed and operated by people who have lived experience with mental health challenges, trauma, and/or extreme states. In my testimony today, I'll review 3 of the reasons why I support peer respite. My first reason for supporting peer respite is partly personal. Our crisis mental health system in Oregon is, at best, strained. As an OHSU psychiatrist, I regularly have the privilege of being the weekend attending psychiatrist for the Adult Psychiatry Consult Service. It's not unusual for our service to be following several people whose physical health no longer requires them to be in the hospital, but who must nevertheless remain in the hospital awaiting an opening on an inpatient psychiatric unit. These kinds of delays increase both the cost and length of care. Because it provides an alternative to emergency room or inpatient treatment for some individuals experiencing mental health crises, peer respite can alleviate the strain on our crisis mental health system and open up treatment space for others in need. My second reason for supporting peer respite comes from the Substance Abuse and Mental Health Services Administration, SAMHSA, which considers peer-delivered services like peer respite to be evidence-based programs that can result in a variety of positive outcomes for participants. In 2009, a SAMHSA-funded analysis of over 1,800 participants from across this country by Campbell and colleagues found that participants offered consumer-operated services as an adjunct to their traditional mental health services showed significant gains in hope, self-efficacy, empowerment, goal attainment, and meaning of life in comparison to those who were offered traditional mental health services only. My third reason for supporting peer respite is simply that peer staff crisis respite programs save money. In 2018, Abushiri and colleagues published a study of nearly 2,200 individuals on Medicaid in New York, in which they demonstrated in the month of peer crisis respite use and the 11 subsequent months, Medicaid expenditures were on average $2,138 lower per Medicaid enrolled month, and there were 2.9 fewer hospitalizations than would have been expected in the absence of the intervention. In summary, peer respite programs are evidence-based support services that can expand the help available to Oregonians experiencing a mental health crisis, result in significant positive outcomes for participants, and save healthcare dollars. I support House Bill 2980, particularly if Oregon's peer respite programs will be well connected to the rest of our mental health system. I ask for your support also. Thank you.
Thank you. Janie Gullickson? Hopefully I got that right. Janie, there you are. Please remember to state your name for the record.
Oh, yes. Sorry about that. I forgot to unmute myself. Good morning, Chair Sanchez and members of the Behavioral Health Committee. I am, for the record, Janie Gullickson, a resident of Beaver Creek in Clackamas County and the Executive Director of the Mental Health and Addiction Association of Oregon. I'm also a person with the lived experience of mental health and addiction challenges, a diagnosis of severe mental illness, but I also enjoy a life of recovery from what I was originally told would be a lifetime of illness. I'm fortunate that I had the kind of support and services that believed recovery would be the outcome, not the exception. The lens I present my testimony in today in support of House Bill 2980 is as a person who worked as a peer support specialist, and now I lead a peer-run mental health and addiction recovery organization. Many of the people we serve who experience mental health distress or crisis have nowhere to turn other than in medicalized environment, such as the state hospital, local hospital emergency departments, and yes, we even in Portland area have a behavioral health hospital, but sadly, these are the only options. And as I am sure each member of the committee are aware, all of these options are expensive and focused on the most extreme instances. Too often, people who reach out for help are turned away for not being acute enough or in crisis enough. Where do they turn? Is the only way to get help is to wait for the crisis to become an emergency or worse? We need peer respite. You have heard amazing testimony regarding the efficacy of peer respite. Peer respite's time has come here in Oregon, and by supporting House Bill 2980, you will not only be filling a huge gap in services, you will be casting a vote that says, we, your constituents, matter, that crisis can just be considered an event, and that we can and do recover when given the right support at the right time. Thank you for your time today.
Thank you. Laura Rose. I'm not going to try to mangle your last name.
Thank you. Dear committee members, my name is Laura Rose, and I live in Marion County.
I'm sorry, Laura, you're a little choppy in there. Wondering if you could, I mean, is that just me or are other people hearing that?
There's something called Hearing Room C that has a mic on. I don't know if that would help.
That's necessary, actually. So I'm going to turn off mine, and hopefully you'll get better. If it remains a little choppy, you might consider turning off your video to see.
Sure. I think.
Okay, didn't hear half of that.
I didn't hear that either. Sorry.
So we may be having a little bandwidth issue. I'm going to.
I could hear now.
Okay, go for it. If you want to just speak a little bit louder, that'd be helpful, and remember to state your name for the record.
For the record, my name is Laura Rose Masera. I live in Marion County. I'm here to testify in support of Peer Respite to HB 2980. I too have lived experience as a survivor of trauma, domestic violence, and mental health challenges. I have served Oregon as a consultant, consumer, and family advocate, working with many of our state's peer-run organizations and peer-delivered services providers. Last March, I launched the Peer Galaxy calendar, which links hundreds of providers of peer support recovery and wellness activities with over 10,000 offerings monthly. I also serve on the Oregon Consumer Advisory Council, the Children's System Advisory Council, and the Oregon Alliance to Prevent Suicide, advising the Oregon Health Authority. As Kevin shared last January, the Oregon Consumer Advisory Council recommended for members of the council with the Oregon Health Authority and the Office of Consumer Activities worked closely on many aspects, itemizing cultural responsiveness by design, budget, staffing, environment, policy, and more for peer respite. Oregon communities, individuals, and families need an option between outpatient services and inpatient hospitalization. There is a body of research on the topic of peer respite showing the benefits, life saved, cost savings, outcomes. PeerRespite.net is a great resource I want to share with you. It's a website by researchers at Live and Learn, and it features research, reports, resources, evaluation tools, instruments mentioned, program manuals, and a directory of programs in 14 other states. Thankfully, through the internet and sites like YouTube, webinars and video tours are readily available with executive directors, peers, and peer supporters speaking to the impact, operations, success factors, lessons learned, and strategies to overcome challenges, including how they're delivering peer respite during the pandemic. Very interesting. So peer respite, as defined, I want to say Oregon has a network of people with lived experience, peers, and peer-run organizations ready to work on this. The planning, rollout, and evaluation of peer respite would be Good to have guided by an advisory group including people of many different cultures and communities across Oregon and key partners. We're available to talk further. Thank you.
Thank you. Sharon Keen, maybe?
Her last name is Keen, and she said she may or may not be available. She submitted testimony.
Good morning. Hi, my name is Sharon Keen, and I was able to be here. Thank you so much, Representative Sanchez and the Behavioral Health Committee. I am a resident of Milwaukee in Clackamas County, and I work as the manager of the David Romphrey Oregon Warm Line and also the Oregon Senior Peer Outreach. I have committed my life to peer support. I am a person who has experienced trauma and altered states or breakdowns that have had me hospitalized in the state hospital. I've lived a life of recovery and focusing on well-being, and I have found that the most healing aspect of my life is the connection with others who have experienced these types of difficulties, and how we share our experiences and how we come to know ourselves as valuable, contributing, intelligent members of the community. And so I'm very busy all the time running the Oregon Warm Line so that we can have peer support to anybody who picks up the telephone between 9 a.m. and 11 p.m. every day of the year. I am so enthusiastic about peer respite in Oregon. I cannot express strongly enough how much this is a particular application of peer support that is very, very helpful for where our system is right now. As others have said, when we're having difficulty, when a person is starting to not be able to live their regular life or do the things that they normally do, we need a support that allows us to enter a safe space where we are in connection, we're in a place where we're not causing devastation and destruction to others. We're being greeted as if we are valuable people. It doesn't require the kind of expensive medical treatment that is available in the hospital. 3.5 years ago, I went through a difficult cycle where I had lost my boyfriend, I had lost my housing, my job was at risk, and I was a wreck. I needed support. A friend of mine took me to the hospital, and I waited in the waiting room overnight, and they never accepted me. Somehow I didn't qualify for that support. If there had been a peer respite, that's where I would have gone. I want to tell you that I worked in California for almost 30 years. I helped with the development of a peer respite there called Second Story in Santa Cruz County. It's a peer-run service in a home-like setting. 7 years after helping to develop that resource of a peer respite in Santa Cruz, I myself fell into a difficult transition and ended up using that service to support me through a difficult time. It is a type of service is that my time up? I just want to say it's affordable, it saves money, it saves lives. It's time for us to do it now. Thank you so much.
Thank you, Sharon. Ann Casper. Ann, are you with us? Ann Casper? I'm not seeing her.
Madam Chair, I don't see her on the list.
Yeah, Madam Chair, I don't see her in the participant list either.
Okay. We're going to go on then. If she happens to pop up, we'll catch her if we make it to the end here.
I'll try to monitor.
Thank you. R. Drake Eubank.
Hello, can you hear me?
Yes.
Thank you. My name is Drake Eubank. I am from Eugene, Oregon. I am a person that helps start what was the first agency that was peer run in Oregon in 2001 that was able to bill Medicaid for what essentially were support services, community-based services provided both through a drop-in center and in the community. that is now morphed into, I and the people that started that were involved in the first certifications and trainings that now train upwards of 1,500 to 2,000 people in the state to do actual work. I would like to speak to a couple of things. One is outcomes, and the other is the qualifications. I get this perception sometimes when people are relying on using terms like lived experience and people that have been in the system. There's a lot of stigma that's attached to that, even now, even when we're trying to be egalitarian about our treatments of marginalized communities. But I would like to make the case for a superlative treatment rather than a derogatory treatment of these people's lives who work in the system. The skills they bring to their job are actually remarkable, and there isn't any university or college you can go to know what it's like to live in a home where you're being abused by an alcoholic parent, or you've experienced serious trauma and managed to recover from it. Those are tools and skills that are extraordinarily hard won and deserve some recognition beyond just simply the catchphrase that they have lived through it or they've had experience of being in the system. It's quite a different thing, actually. And it means a lot more than people give it credit for. Given that, the other thing I wanted to talk about is outcomes. The system a long time has been fairly complacent, and nobody has really demanded much of the system's results over time as much as they have allowed maintenance, mitigation, and lots and lots of requests for more and more money. Money being asked for this, I think, is pretty minimal. And I would like to make a case for letting it prove itself. And if it does, having some real support for it the next time you see it come up in the budgets. And I think peers, for the most part, and people working in the system that have been in the system at times would probably be totally willing to compete on results. And I think that's something worth paying attention to because you have a huge system problem. You have a community, pardon me, all your hospital exits, all the things put emphasis on community-based care, and guess what? You have no support system for them to exit to. The peer respite is just one component of things like that, but you really need a wider support network if you're going to actually get people out of these institutions that I think you're under federal guidelines to get out of right now. Thank you.
Thank you. Zoe, do we have anyone else who maybe signed up at the last minute?
Madam Chair, I don't have anyone else on my list.
Fabulous, thank you. Do folks have any additional questions for Representative Hayden? I thought you might. Representative Morgan.
Thank you, Chair Sanchez. And I guess my one question would be related to, first and foremost, I like this idea. I think we really need it. But is there a database of who qualifies or what the standard or level is for a peer respite, a qualification process of clearing? Is there, as some of these are lifelong, there's times that the provider needs services themselves. And so is there a way to suspend temporarily while they're getting help needed, or that they come along getting help and support if they find themselves also needing help at that time, as a couple testifiers provided? Who's going to monitor the program, or who oversees that process?
Yeah, thank you, Rep. Morgan. This is Rep. Hayden. Thank you for the question. The Oregon Health Authority would be the one that monitors the program, and they have definitions of what peer support is and what peer respites is. When we talk about a peer support organization, we want that lived experience, which I think in this situation is a positive thing. And so it would be the Oregon Health Authority that organizes, we are going to have a couple amendments, that organizes this and then sends it out. You can look at this as a pilot project. I think we need these across we need 36 of them or more, one in every county. But it's hard to get a program going. So this is kind of, the idea is a pilot project to start these programs, track it, and then see where your cost savings is. As far as eligibility of who would be able to access, we want that eligibility open as much as possible, but Oregon Health Authority would lay that.
Thank you. Other questions? Okay, well, let me just say, I actually appreciate this idea very much, and as Dwight Holton mentioned, it is definitely like the third leg of that stool that I believe we truly need to sort of really stabilize the mental health system here in Oregon. We know very well that hospitals are not the best place for folks to end up when they're in a mental health crisis, because there's often not enough room. And my apologies for the noise in my house here. We're doing construction. But we also know that, police are not the right response. So the expanded cahoots model is actually going to be very supportive of that. The 988 situation, where we're actually going to be able to hopefully move to a place where we can actually, create that much more broad spectrum of support for folks in mental health crises is just going to be so very important. So I'm really thankful for this bill and many others that are going to help to try to rebuild this system in a way that makes much more sense. So I'm going to close the public hearing on House Bill, where's the actual number, 2980. And we are actually done for the day, as far as I know, unless there's anything else, Zoe. Oh, reminder that for those who are listening, and that written testimony can be submitted for any of the bills today until tomorrow morning at 8 a.m. Anything else, Zoe?
No, Madam Chair, that's everything.
Representative Solomon, did I see your hand go up?
Yeah, Chair Sanchez, I just really wanted to make a comment to say thank you so much for your leadership in this arena. I think that pre-COVID, we all saw the mental health needs of our students in the Student Success Act across the state. And I think even more now in folks being in seclusion and dealing with so much, whether it's COVID or wildfires or what they're dealing with, and knowing that we're really pushing that message that mental health care is physical health care. It's the same. And I just really thank you for your leadership on this, and I'm very privileged to be part of this conversation.
Thank you. And again, thank you all for your support in this work, and really looking at this from the perspective of, all Oregonians deserve amazing health care, and that, in fact, yes, the mental health aspect of this is vitally important to our physical health as well. So I am going to, end this committee. We are adjourned. Bye, folks.